I'm excited to present to you today and follow up the great work of my colleagues from other rural health research centers and entities across the country. And today I'm going to focus on whether rural racial disparities get lost in the larger discussion on rural-urban disparities in America. Again, my name is D1 S2 Eberth. I'm the Associate Professor of Epidemiology and Director of the Rural and Minority Health Research Center at the University of South Carolina. Rural America is a diverse place, economically, demographically, and socially. In the presentation, I want to focus on how racial ethnic diversity in rural America demonstrate how examining discrete differences in health by rural-urban designation can mask substantial differences across racial ethnic lines. It's important to note from the outset that by race, we mean a socially designed classification, not a biological one, that exposes some to interpersonal and structural disadvantage, and vice versa, exposes some to interpersonal and structural advantage. Today, 1 in 5 persons in rural America is a person of color or an indigenous person. While urban areas are generally more diverse, as you can see from the graph on the right, this is also echoed by Alana's earlier presentation, almost all the population growth in rural areas over the past decades can be attributed to non-white persons, in particular Hispanic populations, who've grown about 2% on average per year. Having visualized the diversity of rural America, let's discuss health and health equity in context. One of the most basic measurements of population health that we've all learned about is mortality. While you've already heard a little bit about this today, looking at mortality aggregated across rural areas can mask key differences in the experiences of people living within those rural communities. In the graph shown here, you can see that age-adjusted all-cause mortality has stayed rather steady in rural white populations over time. This is shown by the red line in the middle of the graph. Rural American Indian, Alaska Native, and Black populations have seen small reductions in all-cause mortality over time, about 0.5% a year for American Indian, Alaska Native populations, and 1% a year for Black populations. Although mortality has declined slightly, rates remain higher for Black and American Indian, Alaska Native residents than their rural white peers. Also, it should be noted, and I believe Mark pointed this out earlier, that from about 2009 onward, the rates nearly flatlined or increased slightly in some groups. Most of the declines we observed were in the early 2000s. We see the most positive reductions in mortality for rural Asian Pacific Islander and Hispanic populations. On average, rural Hispanic mortality declined 1.9% per year, and Asian Pacific Islander mortality declined nearly 2.5 percentage points per year. Both of these groups had consistently lower mortality than their rural white peers throughout the study period. The 3 leading causes of death in the U.S. are cancer, cardiovascular disease, and unintentional injury or accidents. In all 3 of these cases, rural residents experience higher age-adjusted death rates than their urban peers. The largest gap between rural and urban groups is for unintentional injury. In fact, it's about 37% higher for rural residents. When stratified, however, by race ethnicity, you can see that persons classified as Asian and Pacific Islander have the lowest mortality rates for all 3 causes. This is true regardless of urban-rural designation. Black residents have the highest rates of cancer and cardiovascular disease, and American Indian Alaska Native residents have the highest rate of unintentional injuries. Again, this pattern is true regardless of urban-rural designation. One thing I'd like to point your attention to, however, is the fact that American Indian and Alaska Native residents have the largest gap between rural and urban populations. Notably, rural American Indian and Alaska Native residents had unintentional injury rates 60 percentage points higher than their urban peers, and their cancer and cardiovascular death rates were also higher at 33% versus their urban peers. In this slide, I present infant mortality rates for rural and urban populations stratified by race ethnicity. There are 2 main points I'll point out here. First, if you look at the infant mortality rates across all these subgroups, you can see that Black populations have the highest infant mortality rates regardless of rural or urban designation. Second, the largest difference between rural and urban populations is seen among American Indian, Alaska Native populations. Specifically, rural American Indian, Alaska Native residents had infant mortality rates 82% higher than their urban peers. Similar tables that show racial ethnic differences in child health mortality statistics can be found in the special issue on rural health published by Health Affairs in late 2019. So thus far, I've only talked about mortality, but morbidity is also a key population health indicator not to be ignored. So in this slide, I show the proportion of residents who report diabetes diagnosis by race, ethnicity, and urban-rural status. This data comes from the Behavioral Risk Factor Surveillance System, who as of 2018 offers robust indicators of urban-rural status for which to make these type of subgroup comparisons. Overall, we found that non-metro residents had higher diabetes burden than their metropolitan peers. The difference between metro and non-metro residents was most striking for Black populations, where rural Black residents were about 30% more likely to have had a diabetes diagnosis. And although not shown in this graph, non-metro residents were also more likely to have ever been diagnosed with COPD and cancer. With the exception of non-metro American Indian, Alaska Native populations, all other non-metro racial ethnic groups had higher likelihood of COPD and cancer diagnosis than their urban peers. I would be remiss amongst this pandemic not to mention how rurality and race ethnicity intersect in our fight against COVID-19. A new study published in the Annals of Epidemiology found that 52% of COVID-19 cases and almost 60% of COVID-19 deaths occurred in disproportionately Black counties. In their analysis of COVID-19 rates, stratified by urbanicity, the authors found that the relationship between COVID-19 diagnoses and having a high proportion of Black residents was similar across all levels of urbanicity. However, the risk of COVID deaths associated with higher proportion of Black residents was only significant in small metropolitan and non-core rural areas, as you can see in the figure on the left. It's also important to note that 91% of these disproportional Black counties are located in the South, where the majority of Black Americans live, in a region known for high rates of unemployment, uninsured persons, and mostly comprised of states that did not expand Medicaid. The data in this study only included COVID-19 cases from early 2020 to mid-April, so it will be important for us to see whether these trends persist or worsen as the pandemic changes into the summer, with cases on the rise in many states, particularly in the South. For traditionally underserved minority groups, living in a rural area can heighten exposure to unequal social conditions that perpetuate disparities. These social conditions are root causes of health disparities in rural America. They include, but are definitely not limited to, factors like rates of poverty and educational attainment, access to healthcare services, infrastructure and per capita investment in areas like education, lack of public transportation, residential segregation, and racism. As Alana mentioned, the social determinants of health, as defined by the World Health Organization, are conditions in which people are born, grow, live, work, and age. These conditions are shaped by the social determinants can directly or indirectly affect health outcomes of individuals or groups. Some factors like median income are reflections of the underlying characteristics of the people that live in an area. Those are called compositional factors. Contextual factors, on the other hand, represent area-level properties that are often modifiable and not directly tied to individual-level characteristics. An example of this would be state-level policies dictating who can qualify for Medicaid, or zoning laws for affordable housing. Here you can see how social determinants vary within rural communities. Rural American Indian, Alaska Native populations experience high poverty rates and low availability of broadband in their communities. This is particularly important now in light of COVID-19, since schooling has largely moved online and telehealth is needed more than ever for basic health management. Black populations also experience high rates of poverty and lack of broadband access. Meanwhile, Hispanic populations have a large proportion of residents with less than high school education. And while not shown in this graph, Hispanic populations are also the least likely group to report having any health care coverage, based on data from the 2008 Eberth survey. As the data I've shown clearly reveal, there's a compounding effect of rurality and racial ethnic minority status in America. Rural minority residents experience higher mortality rates, more chronic diseases, and are more frequently exposed to social and economic conditions that can create or exacerbate health inequity. So this begs the question, what do we do about it? What interventions would most effectively target disparities in rural communities? Well, while many interventions exist to address disparities, far too few are policy focused, and many were not designed with rural places in mind. Most interventions focused on individual behavior change or require individuals to buy in to a particular service. Interventions that apply to the population at large, not requiring a high level of individual agency, are much less common, but have shown to be more effective. It's imperative that we develop and enforce policies that ensure equitable education, housing, healthcare, transportation, and criminal justice systems across localities, and tribal lands based on their unique populations and needs. Keeping the social determinants of health in mind, it's important that these policies not focus solely on the healthcare system, but also include the macro level environment and multiple sectors to affect real change. I'd like to take a minute to acknowledge my colleagues in the Rural Health Research Center. We have Jan Probst, Anya Zagadic, and Gabe Benavides, who all helped contribute to the figures and graphs I showed. Parts of the presentation were supported by the Federal Office of Rural Health Policy, and here are some resources that you can go to learn more about rural health or to grab data to allow you to do some analyses yourself on rural health outcomes and social determinants of health in rural communities. Thank you.